morning, good evening, wherever you are listening to our podcast. This is SOAP Spotlight on Advocacy and Policy, an ACRO podcast series. We wanted to take some time to discuss our comment letter to CMS that we filed about 2 days ago, just to inform all of you about some of the things we're thinking about coming up in the new fiscal year from the government standpoint. My name is Tarita Thomas. I'm the chair of the Government Relations and Economics Committee, and here with Jason McKitrick and Anna Brown.
Morning, good afternoon, good evening, everyone.
Yeah, good morning, afternoon, evening. I'm excited to be with all of you here and excited to hear more about the comment letter and to discuss more about advocacy and policy with all of you.
Yeah, well, thanks for being here today, the both of you. This is an important time in health policy. There's definitely a lot of things that are affecting us in radiation oncology with reimbursement, with, scope of practice and other things. I wanted to really just focus today on the letter that we submitted regarding hospital outpatient prospective payment and ambulatory surgical care payment systems, quality reporting programs, and what we support in terms of radiation oncology through ACRO. Some of these proposed rules have been things that we've been thinking about for over 10 years, since at least 2010. We have seen that there's been concerns with meeting supervision in rural access hospitals, small rural hospitals. And this is something that I know that we've been discussing as a community within radiation oncology, but then also with our broader colleagues in other specialties. I wanted to ask and have Jason comment upon some of the things that we are concerned with regarding this important topic.
Thanks, Dr. Thomas. So I'll go ahead and share my screen here, and so everybody can see what ACRO did file, as Dr. Thomas mentioned a couple days ago, on the physician fee schedule. As Dr. Thomas notes, there's a lot of issues that we're working on and have been working on over this past year. As it relates to supervision and other issues. I think for purposes of this call, this is really focused in on the PFS comment we filed and some issues that I think deserve further explanation, further amplification, and those relate to yes, there are continued cuts for 2025 that are proposed in this proposed rule. But there are broader issues at play that this letter also talks about, and as Dr. Thomas mentions, that we've been working on for a number of years. For a little bit more context on the proposed rule, the typical rulemaking cycle every year is proposed rule comes out in the summer, final rule comes out on or around November 1st, and that gives you a couple months to sort of get your ducks in a row as it relates to January 1, when the regulation goes into effect, subsequent to that final rule being released. And so there's also, again, in terms of further context, likely going to be some legislation post the election and the so-called lame duck that will address some of these issues, but again, likely in a very short-term basis. A lot of the talk about more long-term PFS reform, I think that has got the potential to spill over into 2025. So some things will be done in lame duck, but based on how things are progressing on the Hill, I don't expect to see any major reform policies being enacted in the lame duck, but we will see. And you've got groups like the Physician Work Group, the Senate, physician work group, that includes about 5 or 6 Senate Democrats and Republicans. They're likely to put out a bill, I would say later this month, earlier in October timeframe, which again will, my understanding is, try to lean into some of these issues, but likely would just mitigate any potential cuts in 2025, but hopefully we'll tee up these broader issues, as I mentioned, for 2025 action.
Jason, can you comment on who those legislative members are, just so that if we have members who are listening to this who are in those districts, that they can reach out and just, voice either their support or questions regarding this potential legislation?
Yeah, off the top of my head, I think there's 6 of them. Senator Stabenow, Cortez Masto, Barrasso, Thune are most of those members. I might be leaving off 1 or 2, but those are some of the key members that are sort of core to this effort. Of course, you also have the Senate Finance Committee and Ways and Means and Energy and Commerce authorizing committees working on these issues. But this work group was put together in the context, really came after the markup, Senate Finance Committee markup last fall, where a lot of the concerns about PFS reform were coming up, and people were saying, well, okay, well, we need ideas. What are the ideas on how to fix this? And some of these ideas we've put in our comment letter, even though it's up to Congress to enact these. It's a messaging to CMS to work with Congress on enacting some of the issues that we bring up in this letter here. So as you see on this second page of our comment, we see another round of cuts in 2025 for radiation oncology for some of our key codes. And part of that relates to the conversion factor. The conversion factor is going to be lower, 32.
Hey, Jason, sorry, before you keep going, just for listeners who may not be familiar at all with what the physician's fee schedule is, do you want to just recap what makes the equation? That like we often will tell Congress people when we are advocating.
Sure. Yeah, very simply, the physician payments under the physician fee schedule are conversion factor times RVUs. And it's good that Dr. Brown jumped in there to explain that, because as it relates to radiation oncology and a lot of the other interventional specialties, what has been happening to radiation oncology and those other specialties really is more on the RVU side than the conversion factor side. That's not to say that the conversion factor doesn't matter. It does. But even a permanent fix to the conversion factor, a permanent inflation update, would not solve what is happening to the freestanding interventionalists, and we'll get into that later on in this comment letter.
Yeah, and sorry, just to jump in again really quick, that's a great point, because with the American Medical Association and other organizations, there's a separate bill in Congress that's advocating for help with the conversion factor. And then there's other efforts focused on, really what will help our field and other technical fields, which is helping with the RVUs. But really, we need help with both to preserve the physician fee schedule.
Yeah, that's right. And again, to sort of close the loop on the conversion factor, I mean, the conversion, it has been a problem for everyone, including radiation oncology, although for us, it's less of the problem. It still is significant. And I think it's noteworthy that, as we say in the comment letter, ever since 2021, physician fee schedule, the conversion factor has been cut. Congress has done things to try to lessen those cuts over time, but the fact is that these cuts continue to get implemented, and it's a sort of a kill me slowly instead of kill me all at once kind of situation here. And the fact is that when the conversion factor cuts are finally phased in, unless Congress acts, that will be a cut of 10%, more than 10% since the 2021 physician fee schedule, which is remarkable to me.
And that's not even accounting for inflation, right? I mean, that's just like base level cuts, which is really challenging.
Correct. Yeah. The other aspect, as we mentioned, however, is, there's another current of most recent cuts on the RVU, relative value unit side, which relates to the clinical labor cuts. Those began to be implemented in 2022 physician fee schedule, and those cuts also have been phased in, not by Congress, but by CMS through 2025. So you have two rounds of kind of cuts, both on the conversion factor and on the RVUs that will be fully implemented next year, which is not great.
Jason, could you talk a little bit about some of the advocacy that's ongoing through ACRO, but then also through groups that represent other high cost equipment specialists that we are involved in ACRO, but along with you and some of your colleagues?
Sure. And I'll definitely talk about that. I'm going to move on here into some additional charts to help contextualize those conversations, and show you all. This is a chart that ACRO and other affected specialties have been commissioning over the last several years, and it shows that within the physician fee schedule, there are, of course, everybody's been affected by these ongoing cuts and the lack of an inflation update per HR 2474, the AMA bill. But within the PFS, some are being hurt worse than others, and that includes, radiation oncology has seen 21% cuts since 06, 07. Other similarly situated specialties that use high cost equipment and supplies, vascular surgery, IR, etc., are in a very similar situation to us.
And I think Anna made a very good point that, this is the physician fee schedule, but we also have to think about, overall how practices are managing all the inflationary pressures that we have with cost of labor, cost of all the other equipment and updates and equipment that we need to do to make sure that our patients get the best treatments. This is on a backbone of continued declines in reimbursement. So, that equation, costs in need to at least equal costs out is not even being met with what's going on with us as physicians. So
yeah,
go ahead.
Oh, sorry, Dr. Thomas. I fully agree, and I think that it's right there on the screen that for over 300 specialties, the cost, the reimbursement is not even equaling the direct cost, not even accounting for anything else. And so to sustain a practice, especially something, in radiation oncology, a small field, there's a lot of small solo docs or, like practices that I've been involved in over the years, where we're just a few of us covering multiple sites. You think of the cost of driving, the cost of, if there's like snowstorms, having to get snow tight, like all these like random other costs are not nearly accounted for. And you think about trying to stay solvent and viable in this day and age, in addition to the hard work we do. This is why the advocacy is so important. And our patients, right? The patients overall, because, right, if just like in developing world, if there's not a linear accelerator, then you can't have radiation facilities. Here in the US, we have a lot of linear accelerators, but if you can't maintain your practice to pay for the machine and other high cost equipment and your staff, then you can't take care of the patients, and the patients will ultimately suffer if we don't advocate.
Yeah. No, that's right. And as Dr. Brown mentioned, this data that we've developed is relatively new on the scene. I would say we're taking the time through this comment letter to educate CMS. We're educating MedPAC, educating the Hill. But the fact that there are 300 services in 2025, that is growing from 195 today in 2024. It's a 50% increase of services where the reimbursement under the physician fee schedule does not even match the direct costs of providing those services. And so, direct costs are about a third of total practice costs per MedPAC. So indirect practice costs also are part of the equation. And then, of course, actually reimbursing the doctor for the work they do. But just looking at direct costs, which are just one element of costs, again, as I mentioned, the dark blue lines here, that's the reimbursement under the physician fee schedule for these freestanding interventional providers, including radiation oncology here. It does not come close in a lot of cases to even matching the direct costs. The direct costs, again, are equipment, supply, clinical labor, okay, mainly equipment and supplies. And it's just not doing it. And then again, as you add on indirect costs, okay, that's overhead. And then as you add on actually reimbursing the doctor for the work they do, we know that there are well over 300 codes. The problem is that the way that the practice expense methodology under the physician fee schedule works, CMS doesn't know what the indirect costs are. They can't tell you for a given code, okay, we know that, the data says that the indirect expense for radiation treatment delivery is X. They don't have that data because the way they build the reimbursement is they take the direct costs and then they use some data that they developed back in 07, 08 to build on that to get an indirect expense reimbursement, but they don't know what the indirect expense costs are. They don't know that. So, but what they do know, and this is all CMS data pulled right from their website, we do know that the direct costs are these dark blue lines. Excuse me, the direct costs are these light blue lines. The reimbursement is these dark blue lines. And we know that at least 300 services here are underwater across service lines, across services.
And that's so interesting to me, Jason, that even using their own data, right? Their own publicly available data, or I'm not sure if it's publicly available, but their data.
It is publicly,
so publicly
right off their
available
website.
data
Yes.
that's from them.
Yes.
We're not even being reimbursed to meet those costs.
Right.
Like let alone, right, you think about the extra time I might spend with patients when they have like a social work crisis because they can't afford to come in for treatment. Well then, right, if we can't afford to meet the, our own needs, then how can we, right, like we have to fill our own cup before we spill over into, like give to patients and other people. So it's a domino effect, unfortunately. And I think that's the unfortunate thing about all this. And, that's why the advocacy is so important to put the silver lining spin on it that, right, there's a lot of good work we can do here, but this data is so important to recognize that there is a gap there. And that gap, the domino effect, ultimately will be giving less to patients when ideally we'd want to be able to give more.
So, I would, and I, those are all really good comments. I think that we, recognize that this physician fee schedule is broken. And I think really what hasn't kept pace is that everything takes time to develop. And I'm sure, I think we care a lot about our patients and we want them to be healthy. I'm sure the government or, the payers, the CMS, everyone really is working towards a goal. But the question is, we're looking at it from different perspectives, okay? And really, what it seems like is that now that technology has advanced so much in our field, I mean, when was the day that we could do adaptive MRI guided radiation therapy. I mean, when I started, we were holding X-ray films up on a light board and we were kind of marking out, where we needed to treat. That is no more the case, right? So technology has advanced so much at such a fast pace, but the physician fee schedule hasn't taken that into account. And I think, we're all working from a place of really good, but we have to kind of come together to see how we can best move forward. And so, I think this is what we're trying to highlight, is that the physician fee schedule hasn't kept up with how fast our technology has advanced. And I'm, thankful, Jason, for all of our collaboration with trying to make people understand it's not just radiation oncology. There are other colleagues who are facing the same crisis that we are. So
yeah. Oh, and sorry. Yeah, Dr. Thomas, just to piggyback off that comment really quick, I fully agree with you. And I think that's the crux of the issue here, right? We know that any government system, our own included, is relatively slow moving due to the grandiosity of it, right? It's a very big system. But right, like our field, which is small, as well as other small technical fields, are nimble in the use of technology, and like in our country, much more so than other countries, right? Where you're right, like adaptive MRI, even adaptive CT based, like the Ethos, lots of machines that you could have in a freestanding center and deliver really, really like high end technology treatments to patients from a solo practice. I mean, that was effectively unimaginable when the PFS was originally developed, or kind of the whole reimbursement schemes. And then you think about other, I know when we did our last virtual ACRO advocacy day, I was paired with a dialysis advocate. But you think of all the dialysis centers out there now, and right, like kidney, doing AV fistula creation, for example, could do it in the office. Like that was kind of, again, unimaginable many, many years ago when this was developed. But that's why, I think one of the key points that you've already made, Dr. Thomas, and same with you, Jason, is we need to advocate for just modernizing the process of reimbursement to match with the services that we actually deliver, so that we can continue delivering them.
Yeah, that's well said. And I'll note that you mentioned AV fistula. That's another one where they're underwater.
Well, that was number one on the chart, right? I was glancing at that chart you had up. That was number one in terms of the pay gap. But then the problem is you can't actually deliver dialysis unless you have an AV fistula. I mean, I guess you could do it, intra-abdominal, but that's much worse. So.
No, you're exactly right. You're exactly right. And there is, interestingly, there is a corresponding rise over the last 5 years or so in catheter use, as these cuts have. I mean, there's been other issues that have, the pandemic and other things have contributed to that, but I think it's noteworthy that we're trying to get rid of catheter use by and large, and dialysis patients. It's foreign object. It's prone to infection.
Well, so that's like one of the biggest things that hospitals get dinged on, right? Is like catheter associated infections, or like preventable UTIs or preventable bed sores. So, right, it's like the reimbursement
Catheter
scheme
rates are
is
going
actually
up.
driving it in the opposite way.
Yeah.
If you just pay for the AV fistula, then you could get rid of some of these issues. Same with radiation, right? If we pay for the radiation machines, then and the reimbursement of the service rendered, then right, patients could get care where they live rather than having to drive 3 hours away to the nearest clinic.
Yep. So, more to say here on the, how these cuts. So for the same 300 codes that we just mentioned here, there's also, this is contributing to the site of service differentials that MedPAC, is concerned about, to their credit. You can see over the last 5 years that the differential has increased for these same 300 codes between the hospital and the freestanding setting, from 43% up to 124%. So it's about tripled, which is terrible. But having said something nice about MedPAC for being concerned about this, I'll say something not so nice about MedPAC, which is that their proposal to deal with this site of service differential by just taking the hospital or ASC rates based on certain volume metrics down to the office rate is just a terrible idea. And and of course hospitals don't like it, ASCs don't like it, and the freestanding guys don't like it either.
Because it doesn't address that cost of the actual service, right? That's the challenge. If you're just going to pay the bottom dollar, then like no one wins.
Right. So we've got some other ideas that would address this site of service differential, and we'll talk about those in a second. These are, as Dr. Thomas, these cuts are, as Dr. Thomas mentioned, are contributing to deserts, especially deserts. We've done some analyses, not just for radiation oncology, but for a number of other specialties, including urology, cardiology, vascular surgery, IR. We'll show the map as we progress through this letter, but just to show you here that is having an impact, we believe, on access to care.
Sorry, just to really quickly talk about that. There's a nice paper by Annie Levine and some others with work out of Hopkins. It actually shows a nice pictorial map of these deserts, and kind of like for each of the counties in the US, you can see like, the color coding of, is there a linear accelerator and kind of radiation services nearby or not? And you can imagine the gap is much wider globally. That's why organizations like Radiating Hope are so important for, providing service equipment and services globally. But yeah, in the US even, right, we have to address what's in our own backyard first, I think. And global is local. And where there's a radiation oncology equipment resource, there definitely is a personnel resource limitation as well.
Yeah, and that's interesting, and for bringing up, Dr. Levine's work. We have spoken with her. I think her article is, very useful, information. It's also very hard to kind of garner that type of information. Because I think one of our interests had been to dive deeper into that. So, like what Jason was talking about, some of the data that we showed earlier in this paper, that was, data that you can get right off of the CMS website. Some of these things, looking at number of physician, quote unquote, providers, and location of sites, that's a little bit more challenging to get that information. So I do commend that work. I think it's an important paper, and shed some light on what's going on. But I think, getting that kind of information for some of our sister specialists who are also high cost equipment users, and how they treat their patients, I think it's a little bit more challenging. So, I know we have just a little bit longer to go on our podcast, and I know you have a question or a comment, Anna, and then we'll just have Jason move forward with talking a little bit more about these deserts. Go ahead.
Yeah, just super brief comment on that, just kind of dovetailing on the discussion we've had about geographical spatial limitations in radiation oncology. So I actually did some work when I was a resident at University of Michigan, looking at within Michigan. Actually, it does result, right, in like practice differences. This is for places that do have radiation oncology. Sometimes there can be racial disparities in implementation of, hypofractionated RT, which is getting a little into the weeds. But broadening it out, I also did my own looking into for social determinants of health, where we can identify just populations of people, right, which are patients as well, who are more vulnerable. There's something called the CDC Vulnerability Index, which is also a county-based map of, effectively, it looks at things like libraries, hospitals, like kind of a broad strokes SDOH, but that is county level too, and that data is publicly available, and I linked to it in one of my articles I've written for ASCO Connection blogs. But beside the point, we need more maps like this, and maybe overlaying them with something like the one that Dr. Levine created, as well as the work that we're doing. We can figure out like where are the most vulnerable patients that don't have access to radiation oncology and help them, and have CMS help pay for it.
Yeah. No, that's true. And there are different ways to look at access. Access, much like PFS reform, is a concept that's kind of thrown around a lot. And there are, when you really dig into it, there are many different ways to look at access. And yeah, you're right. The Dr. Levine et al. Effort is a one way to look at it, they've got a really cool interactive map that they've put up on their website. What we did was tried to develop a model where whatever we would look at for radon could be applied to any other kind of specialty. So we worked with a vendor called Ready Data, and we just asked them, just give us a list of all your doctors for these subset of specialties by county. So this is not site of service, it's specific. It's just, is there a rad onc there or not? Is there a vascular surgeon there or not? So that's how we develop these maps. That's another way to do this, but there are many, many ways to try to look at access. And I agree with you, Dr. Brown, that more development of this kind of data is really important, because policymakers in DC, want to know. They ask, which is a reasonable question to ask. Well, what does this mean for access? And they just kind of say that without, really understanding what they want in an answer sometimes. Yeah.
Sorry to interrupt, but like, how to even get that data, right? Because like you said, you've looked at it from the provider level. Well, some of the efforts I've been involved in, right, including the MROC work at University of Michigan, was from the patient level. So we didn't do this, but I kind of wanted to as an extension of the work, which is like to look at the patient level zip code and see how far they're driving to get their service. Because, right, just because a radiation oncology facility exists where in their county, they may not view it as reputable enough to go there or something like that. So if they're going to drive 3 hours away, then they're using a lot of resources. But you're right, like, yeah, the broad strokes question of what does this mean for access? There's a lot that goes into that, both from the provider level and the patient level.
Exactly. Yep. Okay, so there is to CMS's credit, they're not deaf to these issues. They have been trying to solicit comments for a few years on what to do about stability and predictability, what to do about verifiable data as it relates to practice expense. They're encouraging interested parties to provide an evidentiary basis to develop PE data, and that's all good that they're asking that. What we are telling them is, as it relates to the PFS, we just think that it's really has shown itself to be incapable of incorporating the PE data in a way that's working clearly based on the data we just provided. When you've got at least 300 services that are underwater just on direct costs, there's a fundamental problem. We explain a little bit further that, again, this situation is something that's grown over time. The physician fee, quote unquote, physician fee schedule, when it was set up in '92, was really meant by and large to reimburse doctors for the work they're doing. When you look at these 4 sites of service, I think it's interesting that, the hospital inpatient, outpatient, ASC, these are all technical only, okay? Meaning the stuff that a doctor will use to do their job, the equipment and supplies. It's not, none of these 3 here are reimbursing the doctor for the work they do. The only fee schedule that does that is the physician fee schedule. A physician fee schedule reimburses for work across these 4 sites of service. But then what's weird about it is it's got this other office-based technical piece, and that's really the core of the problem here. Because, in '92, those kinds of things didn't include a $4 million LINAC. They didn't include drug-coated balloons and stents and other kinds of amazing things you could do on a minimally invasive basis.
Because floppy disks were still around then.
Right, exactly. And so, what's that?
Oh, I just said for context, right? Because I remember being a 4-year-old kid at that time and putting a floppy disk in a computer. Right. So I remember that vaguely.
exactly.
I wasn't a 4-year-old kid, but that's a different story. No, I think, Jason, this table is, I think, very impactful, because it clearly shows what the issue is for those in an outpatient physician office. And this is where the disconnect is. And again, where our professional ability to deliver care with very technical equipment is just not being reimbursed in this particular setting. And I think, I think that everybody's looking at this from a different perspective, right? Because that's the perspective you have. And I'm hoping that this can shed light on our perspective so that, some of our colleagues in CMS understand that, we want to provide the best care in every setting. But to do that, we have to be able to do it in a way that doesn't cost us, our own private, yeah, livelihood really is what it is. I am not, of course, in a physician office. I'm in an academic center, but I can empathize with those who are trying to provide this service in a place that needs it, in more community-based settings. So I think this is an excellent table, Jason. I don't want to, I know we have just a few minutes. I don't want the podcast to end, but I think that we really want to highlight that for
Yeah.
our colleagues and, our listeners to hear about.
Well, because then that table gets to the next point I think that Jason you might make, which is right. The weirdest thing about the PFS is that it includes like technical supplies, which could be a linear accelerator in our field, right? In the PFS, which is meant to reimburse physician services, right? That's what it does in all the other settings. So that's the weird thing. If you're paying for physician services and a LINAC, then you're clearly not going to be solvent in the long run if you're not reimbursing at that rate.
Right. And so what's happened since 92, since the physician fee schedule was set up is as technology has advanced and you've gotten these amazing high tech but high cost supplies and equipment that you can do in a community setting, in a rural setting, which is great for patients. What has happened is that as those equipment and supply items have come from the hospitals to those freestanding centers, the money has not gone with it, meaning that the PFS has effectively been subsidizing the hospital, OPPS for years. And that's diluted the PFS over time to the detriment of all specialties, not just the interventional guys, but the cognitive, the primary care guys as well. It's hurt everybody. And so in more recent years, as we showed in that earlier chart, as efforts have been made by policymakers to try to put more money back into the cognitive, that has just further hurt the interventional guys because of so-called budget neutrality within the PFS. And so this all kind of gets to these ideas, and I know we'll talk more about this on our next call, our next podcast here, but the ideas around Rocker, to pull out the high cost radiation oncology equipment from the PFS, is along the lines of, I think, is a step in the right direction in terms of what needs to be done. Pulling out high cost supplies, expensive supplies over $500, consistent, I think, with the longstanding AMA RUC recommendation is a good idea. All these things are things that policymakers, I think should be seriously contemplating as we, really try to put meat to the term PFS reform. That word gets thrown around a lot, but there's not a lot of real ideas to what does that mean? Fundamentally, how do we do that? And I think this concept is a fundamental concept that ACRO and others are digging into to reform the PFS in ways that it needs to be reformed.
I wonder in just the last few minutes we have here for the podcast, if maybe we could go around and just from our discussion today, as well as the context we each have, we could just give a concluding statement of like something to galvanize and hopefully inspire those of us in this field and even in other fields to do this work. And I can kind of get us started off. But in my opinion, right, the physician fee schedule is fundamentally flawed, is broken based on especially that chart that you showed, that all the high cost equipment, including linear accelerators in an office-based setting, are actually then coming from the same pot of money as paying for physician services and all other specialties. So I think, right, it's broken and we need some solutions to fix it, and we need to all work together to do that, which could be through Rocker, it could be through the taking the high equipment supplies out of the PFS. There are a number of other ways, but that's why it's important. So that's my takeaway.
Thanks, Anna. So, I'm not going to kind of revisit this, but I think our letter did a fantastic job. Our discussion today has done a wonderful job. I just want to indicate that, we are not alone as radiation oncologists dealing with this issue, and it's very helpful to work with our colleagues in other specialties that are facing similar challenges. And I think the more that we reach across and build bridges, it'll help us and it'll help our patients have better care. I know there's one other topic on our letter that I really wanted us to discuss. And so Jason, if you want to discuss this, I think it's a very important part. I kind of alluded to it a little bit in the discussion at the beginning, but please go ahead here.
Yeah, I mean, it's fairly self-explanatory, and I believe ASTRO is, in its comment letter, has a similar perspective in that as it relates to the radiation treatment management code that was added to the telehealth list during the public health emergency. CMS is proposing to remove it from the telehealth list for 2025. ACRO agrees with that perspective, given the essential importance of the radiation oncologist to be there in person. So that's, another thing that we are including in this comment, Dr. Thomas.
Well, and just to think about like physical exam being so critical to our field, like I know that, right, like it's one of the few fields where we use almost every aspect of the physical exam. If you're a general radiation oncologist, demoting it to telehealth really takes that away, right? How can you really accurately assess how a patient's doing during their treatment course if you are not there to examine them, and over the screen you don't do an exam? So, yeah, I agree, it needs to be in person.
So, I hope that this podcast has been helpful in the sense that we have reviewed some of the issues that we're working on in the GREC. We value all of our colleagues in the hospital setting, in the freestanding setting, as independent practitioners. And I think that, you can see from our discussion that we're looking at trying to support all those in those different environments. I know this question about the telehealth for OTVs is a big concern for certain members of our community, but I think we have to take a global view and, a higher perspective as to why we need to maintain this as a in-person visit. So our kind of conclusions may align with ASTRO, but we came to them from our own evaluation and thought about why this is important. So I want to thank everyone for their time today, for taking the time to participate in the podcast. Jason McKitrick, really appreciate your work with us and support. And Dr. Brown, thank you for spearheading this effort to get our message across in various platforms. And one thing I want to just mention is that we do have a PAC, the ACRO PAC. Is now being led by Dr. Heath Mackley, and we really would appreciate your support with the PAC. Jason did highlight the members of Congress that are working on issues that affect us. So if you're in one of those districts, consider reaching out and reach out to us if you'd like to have those introductions. So thanks for your time. Thank you, Dr. Brown. Please go ahead and conclude the meeting.
Yeah, excellent. Thank you all so much. Been wonderful being here. Thanks so much to both of you. Thanks, Jason, for all the perspectives. Thanks, Dr. Thomas, for leading the GREC. You're a wonderful leader and excellent mentor, and really looking forward to continuing this effort with all of you, and hoping that all of you listening will also want to jump in and not only contribute to the PAC, but contribute with time and interest in these issues which affect all of us.
All right.
Thanks, everyone.
Thank you.